YouTube Music can help you find that song from last night. The one that goes.
Nobody listens to the radio, baby.
Use Smart Search to find songs with just a few lyrics. Upgrade to YouTube Music Premium. Uninterrupted music dedicated to you. Try 1 month free.
Rent or buy The New Mutants on YouTube. See the thriller everyone is talking about on your go-to app for videos. Watch The New Mutants on YouTube.
How long will I slide? Separate my side. I don't believe it's fair. Slitting my throat is all I am. The hurting voice to the photograph. I thought that I've been brought up the path. Once you know you can never go back, I gotta take it on the other side. The century I what it meant to me. The cemetery where I'm buried to see. The strangest thing that never changed my mind. I gotta take it on the other side. Take it on the other side. Take it on. Take it on. How long will I slide? Separate my side. I don't believe it's fair. I'm slitting my throat, it's all I am. Pour my life into a paper cup. The ashes full and I'm spilling my guts. She wanna know am I still a slut? I gotta take it on the other side. The starry side, she's in my bed. A candidate for the soulmate blend. Was a trigger and a pull of bread. I gotta take it on the other side. Take it on the other side. Take it on. Take it on. Separate my side. I don't believe it's fair.
Hey, Dr. Capullo. Yes, Dr. Bennett, how are you?
Hey, how you doing today?
Good, good.
Glad to see you.
Me too.
So how are things in where are you at?
Congo.
Oh, okay. How are things over there?
Yeah, everything is okay. What about that side?
Okay.
Hello, everybody.
Hey, who's that?
Hello, everybody. Abubakar Shomo.
Hey, good to see you.
Ah, nice to see you. How are you?
Is your picture working or no?
No, no, no. That
Okay.
is just this fixed background.
Oh, okay.
How are you?
Good. You can get a background like I do.
Yeah.
And Dr. Kabulo has a background usually that shows
Yeah.
that river, Dr. Kabulo. Do you know that background you had, remember?
Which one?
The one that you showed the river on the
okay.
border
Yes,
of the border of the Congo and the
yes, and the other Congo. Yes, let me try to put it.
yeah. Oh, you got that background. You see the background, Vlad, of Dr. Kubulo?
Yes, Dr. Bennett.
Yeah, that's it. The river between the Congos, right?
Yes. That's the Congo River separating the two Congo. So this side it's Kinshasa, the other side it's Brazzaville.
Okay, and they're both capitals, right?
Yes, both capitals.
That has to be the only place in
The closest capital cities in the world.
that has to be the
It's just
only
the river. Sorry?
that has to be the only place in the world where there are two capitals across the river, you know,
Yeah.
from each other in the world. That has to be the only place in the world.
Sure.
Greetings, everybody. We start in about 4 or 5 minutes if Dr. Sabea shows up. That's always nice, wondering if the speaker's going to show up. But usually it's okay. But you get nervous, you know. Hey, Dr. Sabea,
Hello,
how you doing today?
I'm fine. How are you?
Good, good. I'm glad you're restarting.
Yeah, I told you there was curfew, there was a big election here and a lot of problem, and then they opened up again.
Good. You saw the promotion, right?
Yes, I did. Yeah, thank you.
Yeah, we put it. What's up is great. You know,
Absolutely. Imagine 20 years ago, what did we do? We had no.
yeah, I know. It's a great tool. It's a great platform, and we'll just restart and bring left. Of course, there'll probably be some time you take off over the holidays, right?
Yeah, true.
Yeah, sure. Just let me know ahead of time.
Sure.
Everyone's kind of slowing down. Okay, we got 1 minute.
Sure, I'm
Okay,
ready. Whenever
yeah,
you-
yeah. So, yeah, I'm getting more organized. Like right now, I have one computer set up with my mailing list, and soon as it starts, I press a button and it goes out to like 8,000 people live. I mean, it goes with the video playing, which
Yeah.
is great. And the
Absolutely.
other computer I have is on Facebook, the Facebook groups. So I just punch them that it's
Yeah.
starting.
Yeah.
So for me, it's a busy time. So, okay, we're ready to start. Okay,
ready.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from sunny Miami Beach. This is Dr. John Bennett restarting the Jordan Neurosurgery Grand Rounds with Ibrahim Sabea. And we're glad he's restarting again. And welcome to all the panelists. And I'll turn it right over to Dr. Sabea. Welcome back, Dr. Sabea.
Thank you very much indeed, John, and I'm glad to see you again. They had some problem in Jordan regarding the COVID cases, so we had curfew, and we could not get to the clinic and to practice and prepare lectures. So we're back. I'm happy to say that. For those who don't know me, my name is Ibrahim Sabea. I am speaking to you from Amman, from the Farah Medical Campus. I chose today to put a very unique subject, just for the sake of opening eyes for people who don't know it, and to discuss this issue with people who know about it. The topic is hypothalamic hamartomas. The abbreviation is HH, so hypothalamic hamartomas, from the clinical, radiological, operative, and pathological correlation. So before we go into the pathology, let's remember some of the anatomy facts about the hypothalamus. So hypothalamus is the foreground structure sitting here on the floor of the third ventricle. This is the thalamus, this is the hypothalamus, and this is the sulcus between the two. So if you look like this, the hypothalamus looks like the head of a bird. It has a roof, the third ventricle, the back wall of the third ventricle, and the floor of the third ventricle here is the midbrain, and then mammillary bodies, tuber cinerum, and then you get the infundibulum and the stalk. So this is a close look, a floor of the third ventricle where the hypothalamus is, the mammillary body, tuber cinerum, the infundibulum, and the stalk to the pituitary. If we look from underneath the brain surface, you can see the mammillary bodies, the tuber cinerum, and the stalk. So this is a very important area where we have to remember the anatomy. Again, a cartoon of the area, the mammillary body, and the tuber cinerum, and the infundibulum and the stalk. This is the nuclei of the hypothalamus there. So we have lots of nuclei in the floor and in the lateral wall of the hypothalamus, and they are arranged in terms of paraventricular, intermediate, and lateral. From medial to lateral and from anterior to posterior. Why am I saying that? Because the pathology of hamartoma starts here. Either it involves the mammillary body, or involves the tuber cinerum, or involves both. So we'll have consequences that we'll discuss later. Again, here we have to remember the limbic system and the relationship to the hypothalamus. Limbic system made of hippocampus, amygdala, septal nuclei, cingulate cortex, perirhinal cortex, or hippocampal cortex, olfactory areas, the hypothalamus, the thalamus, and the reticular formation. Again, here's the depiction of this. This is the amygdala, and this is the hippocampus, and then we go into the fibria of the fornix, and the crus of the fornix itself body, and then the columns of the fornix, and then we go into the septal sulci, the olfactory bulbs, and then from the mammillary body we have the mammillothalamic tract, and then we go into the thalamus, and from there we'll go into the cingulate gyrus. So it's a huge thing of the limbic system. So again here showing you the amygdala and the hippocampus, and then we get the fornix, and then we have the cingulate gyrus. So all this is the limbic system. Papez, or James Papez in 1930, discovered what's called as Papez circuit, which is the medial limbic circuit. And this has been found to be very much related to memory and emotions. Why am I saying this? Because when we discuss the hypothalamic hamartomas, we will discover the effect of the hamartoma on the memory and in emotions, in addition to other things. So Papez circuit starts in the hippocampus, going to the fornix, and then into the mammillary body, and then we have the main tract, mammillothalamic tract, that will take us to the anterior nucleus of the thalamus. From there we go into the cingulum, we go around the corpus callosum, and we go into entorhinal cortex, back into the hippocampus. So this is the Papez circuit. You start in the hippocampus and you end in the hippocampus, and it's very much related to both functions, memory and emotions. Again here, just to reiterate what I've just said in relation to the relation from the mammillary body to the thalamus, mammillothalamic tract, and from there you go everywhere. So what is hamartoma? Now we know the anatomy. We are speaking about hypothalamic hamartoma. We know the anatomy of the hypothalamus and the relationship to the limbic system. to the memory, to the emotions, etc. What is a hamartoma? Hamartoma in Greek means hamarration, which is defect, something which was not done in good fashion. So it is a normal structure components, normal, but they are present in disorganized body. That's the name, hamartoma. Normal structures, but they are disorganized. So they resemble tumor, but they do not have a neoplastic evolution. They grow at the same rate as the tissue from which they are derived, while a tumor will grow faster than from the tissues where they arise from. The hamartoma, they will grow the same rate like the structure they are derived from. So again, hamartoma is an abnormal mixture of normal tissues and cells from the area in which they are grown. They can be in any part of the body: skin, neck, lung, heart, breast, spleen, and brain. And here is the depiction of the hamartoma in the brain. So in summary, hypothalamic hamartoma is a congenital, developmental, non-neoplastic malformation. Don't be deceived by this. They can have detrimental effect on the patient. This anomaly that will cause the hamartoma, the defect, it starts at the 4 to 7 weeks of gestation, anomaly of a neuronal migration, and we get normal neurons and glia, but in abnormal distribution. And for some reason, they are more prominent in males than females. So how do they develop? Why do they develop? What are the theories of this happening? Either there is an ectopic localization of normal cellular elements, they are put in abnormal localization, or the cells are positioned normally, but they have abnormal proliferative potential, yet they are not tumors. Where are they located, these hypothalamic hamartomas in the brain? They are in the hypothalamus, and they are either occur at the mammillary body, or they are occurring at the tuberosinium, or both locations. Each location has a specific presentation. Is it common? No, it is rare, 1 in every 200,000 population. Cases reported to be diagnosed in utero at different gestations age. They have different classification. I looked into literature, they have so many classifications, but I dropped most of the classifications which are not useful to concentrate on the useful ones, the main one, actually. This is called Galande and Follin classification. Type 1, type 2, 3, and 4. Easy. Type 1 has a horizontal attachment. Type 2 has a vertical attachment. Type 3 have both attachment, vertical and horizontal. And type 4 is the giant. Look at them again. The Lande classification. This is type 1. As you can see, horizontal orientation, vertical orientation, both orientation grade 3, and if they are giant, in grade 4. So this is grade 1, and most of the time grade 1 has a pedicle, so it is called pedunculated hypothalamic hamartoma. They have this vertical attachment, vertical and horizontal attachment, and type 4. Again, which type is the commonest? The commonest is the type 2, which is a vertical attachment, followed by this, which is both, as you said, and then we have the giant ones and the pedunculated. So pedunculated are the least common, while the most common is type 2. So type 1, type 2, 3, and 4. This is the most famous accepted universally classification of the hypothalamic hamartomas. Other classifications are there: intraparenchymal of the hypothalamus, parahypothalamus, this, that, and the other. Forget about them. This is the main classification which is accepted everywhere. And we'll go through them just to be sure that we know exactly what do we mean by type 1. So type 1 is called parahypothalamic. It's horizontal attachment, as we said, and it has a peduncle. So horizontal, lateralized, pedunculated. This is a grade 1. Examples: grade 1, grade 1. Look at this here. It could be small, it could be large. but still we are talking about type 1. Type 2 is the vertical one, as we said, vertical plane of attachment. So here you are, vertical, vertical. Examples on the MRI, so that we can correlate the number with the image. Type 3, both attachment, vertical and horizontal. So this way and this way. So this is type 3. Type 4 is the giant one. It has a broad attachment. So here we are, the giant one, giant example. So look at this. As I said, don't be misled that this is not a tumorous, this is non-cancerous, whatever. They can have detrimental effect on the patient in terms of a pressure, obstruction of the CSF pathways, and very, very advanced neuronal and neurological manifestations, especially the giant ones. So summary, grade 1, grade 2, 3, and 4, grade 1, 2, 3, and 4. Regis, John Regis from Marseille, France. He's a very famous radiosurgeon. He published lots of papers about the hypothalamic hamartomas, and he said we'll add 2 types of the classification to Delande, type 1, type 2, 3, and 4, and 5 and 6. So really, you cannot apply it into practice, so better stay with the Delande classification. Can they be unilateral? They can be bilateral. Unilateral in 70% of cases, bilateral to be attached to both surfaces of the hypothalamus, to both hypothalami, is in 30%, and in bilateral, sorry, this is bilateral, this is unilateral. If we come and look at the histology of this, let's have a gross appearance. They are brownish, whitish, relatively avascular. They have a little bit of tougher consistency in relation to the surrounding structures, but usually you cannot differentiate from the surrounding tissue, surrounding hypothalamic tissue. If you look at the histology, what they are made of, they are made of neurons. We have 2 types of these neurons. We have glial cells, but they are in disorganized pattern, and hence the name, hamartoma, they are disorganized. So again, developmental malformation made of mature neurons, glial cells, and dysplastic neurons. And if we take the neurons, they are the normal neurons of the hypothalamus. We have small neurons, and we have large neurons. These are the most important ones. I will allude to this later on, because these are gamma aminobutyric acid secretory. So they fire like hell when the patient has hypothalamic hamartoma and cause major epileptic disease. So small ones are the commonest, 90%, large ones are less. These are the GABA expressing neurons, and these are the quiescent pyramidal neurons. So this is the small neurons, this is the larger neurons. They have extensive arborization of the dendrites and the axons, while the small ones, they have control over these large ones, and then they can transmit their electrical discharge into other areas of the brain. So these are the small neurons, they are really small. And this is the modified Golgi technique of staining these small neurons so they come in different shapes. Again, the most important fact about these small neurons that they are GABA expressing neurons. They are GABAergic neurons with a spontaneous intrinsic pacemaker-like firing. And they are the cause of epilepsy in hypothalamic hamartoma. Close look, magnified look at these small neurons are characterized by these dense chromatin within their nucleus. And they are called neurocytes, as you can see. they can come in form of nodules, as you can see here, they form nodules. And sometimes they are diffused, they don't form nodules. So this one is called nodular type. This type is called diffuse type of neuron, small neurons. The larger neurons, also called ganglion cells, as we said, characterized by the extensive arborization of the axons and dendrites, and they are characterized by the presence of nissel bodies. Again, here they are stained with modified Golgi technique. You can see the extensive arborization of these large cells. And these are pyramidal cells. They are coexistent, but they are controlled by the small neurons. So here you are, the ganglion cells or the large cells and the mixture of the small neurons. Small neurons 90%, ganglion cells or large cells are only 10%. In addition to the small neurons and larger neurons, we have glial cells, and we have also myelinated axons. These will form the histology of these hypothalamic hamartomas. If we come to the immune staining, GFAP, synaptocene, neurofilament, phosphorylated, internexine, Ki67, CD68, they are all put on the specimen when you send it to the histopathologist. And there is a new neuronal marker called NEU-N. This stains strongly as a marker for mature neurons. So when you see, when the histopathologists look at this and put the NEU-N, then it is one of the immunostaining markers for the hypothalamic hamartomas. They are synaptocene positive. And here, if you stain them for the gonadotrophin releasing hormone, they will stain positive. And this is important because one of the manifestations of the hypothalamic hamartoma is to secrete gonadotrophin releasing hormones, and this will cause manifestations of the so-called precocious puberty. So we know now that they can present with epilepsy due to this GAPA cells, and they can present with precocious puberty because they secrete the gonadotrophin releasing hormone. So how do they present? So already started speaking about the presentation. One thing that we should remember that they can be asymptomatic. This is autopsy of a man who died at the age of 60 from a car accident or whatever. His autopsy showed that he had this hypothalamic hamartoma, but he had no manifestations whatsoever from that. Remember, asymptomatic presentation. But usually they do present. Most of the time they do present, and they present usually between 1 and 3 years of age, either with seizures, which is 50%, precocious puberty, and 75%. And this, as we go along the age, we will get behavioral disturbance, psychological disturbance, and cognitive decline. Why? Because the hypothalamic hamartoma is connected to the Papez circuit, which will affect all this, emotions and cognition. If the hamartoma is attached more to the tubal cinerum, is different from when it is attached to the mammillary. If they are attached to the mammillary, the main presentation is epilepsy. If they are attached to the tubal cinerum or the stalk or the infundibulum, they're more of endocrine, so they will present with precocious puberty. So the presentation is either precocious puberty or precocious puberty with seizures or isolated seizures. So isolated precocious puberty, isolated seizure, or both. And it was found that the sessile hamartomas, they more develop, they more present with seizures, while the pedunculated one, they usually present with the precocious puberty. What are the presentations of these hypothalamic hamartoma in terms of seizures? It is called gelastic seizures. And what does that mean? Gelastic seizures is the most intriguing syndrome in epileptology. It is a type of epilepsy in which seizures are gelastic. What does that mean? Gelastikos in the Greek means laughter. So it is epileptic form that comes in the form of laughter. Gelastic, Latin for laugh. But there is another type of the lesion in the hypothalamic hamartoma itself called diacrestic, and this means tears. So the patient may have laughing episodes or crying episodes or combination of both. So gelastic seizures as epileptic form was first described in 1873 by Trousseau. 57, almost a century later, Daly and Mulder, they coined the term gelastic epilepsy, and they coupled it with the hypothalamic hamartoma. They found some correlation. In 71, Gascon and Lambros, they defined the characteristic of this gelastic seizures. So what did Trousseau said? He described the case, 1868. He said like this: the boy experienced a burst of laughter for a few seconds. Then he recovered rapidly, being very surprised and being not aware of what happened. So that was the first description of the gelastic seizure, 1868. 1871, Gascon and D'Ambrosio, they put the characteristics and the definition of the gelastic seizure. It is a stereotypic recurrence of ictal laughing, inadapted to the context, associated with other signs compatible with seizure and with ictal, interictal, EEG abnormalities. So these are the criteria to diagnose the gelastic seizure. It's a brief laughing, which is unnatural, not associated with happiness. This is very important. When you laugh, you should feel happy. But those people, when they laugh, as if they are forced to laugh, and they don't have a mirth, they don't have happiness. And this laughing is unmotivated. There is nothing that would cause them to laugh for. And it sounds like mechanical laughing. So I'm just giving different descriptions of this gelastic epilepsy. Sudden laughter, it's hollow, it's empty, it's not pleasant. Even if you hear it, you're not happy, and you know he is not happy, and there's no obvious reason why he is sort of smiling or not laughing. It is totally out of place, it lasts for 1 minute, and maybe followed by focal fit. Another description: laughter without emotional content, followed by motor or associated with motor tics. Head is deviated. There is arm and leg movements, vocal tics. There are hallucinations, staring of gaze, pale face, flushed face, automatism, lip smacking, mumbling, fidgeting with his hands. So all this would tell you that this is a gelastic epilepsy. Why am I saying this? Because if you see a kid, 6 months or 1 year old, and he is laughing or crying, this is not a laugh. This is not a joke. This could be misleading. You may sort of not discover this, and the patient would have major consequences. Is it pathognomonic of hypothalamic hamartoma? The answer is no. It happens more in hypothalamic hamartoma. It's one of the landmarks of hypothalamic. It is not pathognomonic. It can happen in a frontal epilepsy, temporal epilepsy, can happen in cortical dysplasia, tuberous sclerosis, in tumors in the area of the hypothalamus, pituitary tumors, hypothalamic gliomas, suprasellar meningioma pressing on the hypothalamus, basilar artery aneurysm reaching there. The commonest, the gelastic seizure is hypothalamic hamartoma. It can happen in the others. What about the gelastic epilepsy that we see in hypothalamic hamartomas? They found that the hypothalamic hamartoma is the engine that starts the gelastic seizure. So gelastic seizure is produced by the hypothalamic hamartoma. And it could be gelastic or diacrestic, laughing, crying, or both. And these are the hallmarks of hypothalamic hamartoma, especially that happen in the early infancy. As we go along, these gymnastic seizures will disappear and they are replaced by an awesome bad epileptic syndrome. So there is an intrinsic epileptogenic focus from the hypothalamic hamartomas. How do we know this? This was confirmed by the depth electrode recording, by scalp electrode recording, by sphenoidal electrode recording, by ictal SPECT. And you could see that this electrical activity propagates to the brainstem, to the reticular formation, to the subcortical centers, to the frontal and temporal areas. So first year of life, gelastic or diachronistic seizures, and then the following years, you have epileptic encephalopathy. Complex partial seizure, tonic-clonic, drop attacks, absence attacks, generalized epilepsy, or status epilepticus, or status gelasticus. So again, the cause of these gelastic seizures are these neurons, the small neurons, which are gamma aminobutyric acid secreting. They are causing firing spontaneously, and they are driving the pyramidal large neurons into also activity. Once you see them, you have to treat them as focal seizures, carbamazine, lamotrigine, whatever, but the epilepsy associated with hypothalamic hamartoma is very resistant to drugs, and it is usually associated with severe psychiatric and cognitive comorbidities, as we will see later. Some people try to treat this epilepsy with anti-epileptic drugs, with vagal nerve stimulation, with deep brain stimulation, DBS, like you do with the Parkinson, but the success rate is not high there. Let's see how the gelastic seizures, so that we can understand and can see how we can easily misinterpret as this is a normal child. So this is a boy who's playing. This is diachronistic. So we have seen in the videos different types of these gelastic seizures, laughing, then followed by crying. Both of them they can be followed and associated with head movements, arm movement, grimacing of the eyes, grimacing of the face, and they can be followed by smacking of the lips and so on and so forth. And they can follow with the, as I said, seizure in the various forms of seizures. As I said, it is difficult to diagnose, especially in infancy. We all have kids, and we love for them to laugh. But remember, maybe this is not fun. This is not a joke. Maybe this child has some serious disease. So I have to follow and see what the things that they are associated with this laughter or crying. It's important. Usually, this is misinterpreted as normal laughter or abdominal colic. That's why he's crying. The other presentation, as we said, the epilepsy thing happens with these hamartomas that are located in the posterior part of the hypothalamus, on the mammillary bodies. But those who are more anterior in the tuberosinirum or into the infundibulum and stalk, they will present with precocious puberty. And this is a picture of one of my patients. He's 1 year old, but look at his genitalia. It is the genitalia of an adult. Before we speak about precocious puberty, let's speak about normal puberty. What do we mean by puberty? And then what do we mean by precocious puberty? So puberty in general, girls get earlier than boys, 8 to 13 years in girls, 9 to 14 in boys. This timing is affected by so many factors: hormonal, metabolic, environmental, ethnic, and genetic factors. So puberty, to attain puberty, is a complex biological process regulated by so many dynamic interactions between so many determinants and regulatory factors. This is normal puberty. And this does not happen once. It goes into sort of bursts, gradual. As we said, this is the definition. And it is all caused by the gonadotrophin-releasing hormone, which comes in bursts. Where is it secreted by? By the hypothalamic neurons. And as I said, this event is triggered by many factors. So this is the gonadotrophin-releasing hormone neuron, and it's affected by so many GABA neuron that can be excitatory or inhibitory here, and so on and so forth. So many factors affect this. But again, in normal people, normal boys and girls, when they attain puberty, this gonadotrophin-releasing hormone comes in bursts, and sort of slowly in bursts, not continuous. So here you are, the gonadotrophin-releasing pulses that will affect the pituitary, and we start secreting of the FSH and LH, follicle-stimulating hormone, luteinizing hormone. When we speak about males, what does that mean? They attain puberty. There is some testis enlargement, and the skin color and shape and the odor changes. Why? Because the skin of the scrotum has sebaceous cyst that will give it special odor. There is penile enlargement. There is growth spurt, and as if the boy suddenly gets taller. His bone age will advance, his voice will break, and he will develop pubic and axillary hair. This is normal puberty in males. In girls, the breasts start to develop, again, the growth spurt, bone age advancement like males, and then menses starts 2 years after the breast, and then the pubic and the axillary hair. This is, again, normal puberty signs in males and females. So what do we mean by precocious puberty? We mean something that happens to puberty. It comes earlier, before the age of 8 in the girls, before the age of 9 in boys. Sometimes there is familial precocious puberty when we have many members of the family are affected. What is the cause of this? It is the hypothalamic hamartoma that caused this precocious puberty. Why? There is premature notice. Shouldn't happen at that age 2 or 3. Premature activation of the hypothalamic pituitary axis, caused by, of course, as I said, the hamartoma, and then it will stimulate this, causing the gonadotrophin to be secreted in a high dose. So there will be early development of secondary sexual characters, rapid growth in length and in weight. Precocious puberty is classified either central or peripheral. In peripheral, it's not gonadotrophin related, while central is gonadotrophin dependent. If we take that, the central precocious puberty, this is the commonest type, idiopathic type. They just get the puberty early. And this is, they are normal in every aspect, idiopathic. Some genetic factors, some environmental factors, whether you are living in a cold climate or hot climate, whether you are subjected or affected by some environmental pesticides or whatever, and adoption. It was noted that adopted members, adopted people, boys or girls, they get precocious puberty earlier than the others. But when it comes to the central precocious puberty as secondary, and this is, as you said, common in males. So remember, the idiopathic precocious puberty is more in females. In males, it is usually a secondary precocious puberty, and it is related to the hypothalamus hamartoma, glioma, ependymoma, arachnoid cyst, pharyngoma, germinoma, in the area of the hypothalamus. Or the brain and the hypothalamus in particular was affected by radiation, by infection, by bleed, by granuloma, or even head injury. So again, just reiterate that the hypothalamic hamartoma, which is in touch with the stalk or the tuber cyanerum, is the one that caused the precocious puberty. The one attached to the mammillary body is the one caused with epilepsy. Again, activation of the gonadotrophin releasing hormones, producing these ictal pulses. Example, case history of female, 7 years of age, breast development, Turner stage 2, typical starts to develop, menses, height is 137 centimeters, born age 10 years. She's 7, but her born age is 10. And give the treatment, which is the gonadotrophin releasing hormone, the breast size will regress, she will grow well, and she will attain the normal size. So you continue the treatment till the age of 10 to 12 years. That's in the precocious puberty, but not in the ones that is caused by tumors, because you need to, by the hypothalamic hamartoma, you need to treat that as well. So if you have a case of central precocious puberty, it may be normal, it may be idiopathic, but it could be something serious. So studying the history, observation of the patient, and then you go for brain MRI to prove whether you have something in the hypothalamic area. You need to do skeletal survey to know the age, bone age. You need to do genetic testing. Again, here, the things that you do: X-ray for bone age, hormonal assessment, brain MRI, abdominal ultrasound. You can see increase in the uterine volume, or fundal cervical ratio is increased, and the presence of endometrial echo in females going into precocious puberty. What is the treatment? The aims of the treatment is to reach to attain the adult size and to synchronize puberty with peers, because you can't have a girl in the elementary school at the age of 5 and she's having menses. Her peers would actually attack her. And to decrease the psychological effects of this, especially in adopted babies. So the treatment is gonadotrophin releasing hormone. This was discovered back in 1970. If you give a steady high level, this will suppress the hypothalamic pituitary axis. Remember, this is a steady high, not like the burst of normal puberty, which comes in burst. The gonadotrophin is released in burst, not as steady like in the treatment. This will lead to regression of all these secondary sexual characteristics. It will slow the skeletal maturation, and the patient will attain the appropriate size. Some people would combine the gonadotrophin releasing hormone with the growth hormone. So gonadotrophin releasing hormone analog called the treatment is preservation of the height, decrease the psychological consequences, and you stop the treatment when they attain the height and when you control the functions. This is something like at the age of 13 years. This gonadotrophin releasing hormone is available in terms of intramuscular injection, monthly or 3 monthly or 6 monthly, depending on the country, USA or Europe, etc. It's very, very expensive. It's $30,000 to $50,000 per year, and you need to give it for about 2 to 4 years. These hamartomas, they can happen isolated, or they can be part of a syndrome. And the most famous syndrome of this is the so-called Pallister Hall syndrome. But the majority are isolated, they are not syndromic. So Pallister Hall is Philip Pallister and Judith Hall, who described this back in 1980. Since then, only 100 cases have been described. They have seizures which can be controlled by medicine, but the clinical course could be bad. And this is caused by mutation in GL13 gene, and it is autosomal dominant, and the risk of passing this to offspring is 50%. And this syndrome is made of so many components: hypothalamic hamartoma, which is the main thing, but there is polydactyly, imperforate anus, laryngeal abnormalities, abnormal teeth, short limbs, cardiac, renal, genital hypoplasia, and hypopituitarism. This paper in Neurology 2019, hypothalamic hamartoma and polydactyly. If you see that, think Pallister Hall syndrome. This is the hamartoma, and this is the polydactyly. So many forms of this polydactyly. And they have these teeth abnormalities. So if a patient is having gelastic seizure, is having precocious puberty, you look into his teeth, you look into his arms and legs, then you can diagnose the syndrome, Pallister Hall syndrome. Another paper in the Genetics 2019, again showing polydactyly with hamartoma, and usually you can see that the hamartoma is the giant type, it is type 4. Again, Pallister Hall syndrome with orofacial narrowing and tethered cord. In addition to what we said, there's something like tethered cord here. In addition to the presentations that we mentioned, which is epilepsy and precocious puberty, these people will get psychiatric disorders, oppositional defiant disorder, attention deficit hyperactivity syndrome, autism, conduct disorder, affective disorder. In addition to variety of anxiety disorders, social anxiety disorder, obsessive compulsive disorder, specific phobias, panic disorder, affective disorders like depressive disorder, dysmenorrhea, pervasive developmental, avoidant, schizophrenic. And these are the things that you look for in these patients by asking for a psychiatric consultations and to ask the family to observe the patient and to look into the various disorders that we have mentioned. In addition to the psychological disturbances, they have high behavioral changes. They are hyperactive and they have aggressive behavior. And this comes in terms of rage attacks. And people describe this as epileptic attack. So rage attacks in those patients is actually an epileptic attack. They can be disinhibited, inappropriate behavior, and of course there will be decreased cognition, decreased concentration, and autism. So they will have difficulty in verbal learning, verbal memory, verbal recognition, in addition to visual learning, visual memory, and visual recognition, and their short-term memory is affected. Remember, this is all caused by the hypothalamic connections with the limbic system and the Papez circuit. What about pituitary functions? Where usually deficiencies are not present at diagnosis. And this is important when you come to differential diagnosis. I will allude to this later on. What kind of investigations do we need to do for these patients? It needs a team of neurosurgeon, neurologist, pediatrician, endocrine, ophthalmologist, and neuropsychologist to deal with such a patient. You need to have images, MRI, CT scan, you need to do EEG for 3 days, video encephalogram. You may need to do SPECT, during the attack, ictal and interectal. You need to look at the vision, visual fields, and the neuropsychological assessment. Images. Let's see what do we see in these hypothalamic hematomas. CT you would see a lesion in the area of the hypothalamus, which is iso dense to the brain. It's non-enhancing. Sometimes there is some cystic changes and calcification in large tumors. Examples, you can see this. They are iso-dense to the gray matter. The MRI, as I said, mass in the hypothalamus. In T1, it is iso-intense. In T2, it is hyper-intense. That's in relation to the gray matter. Usually there is no calcification and there is no contrast. So this is T1, iso-intense. You can see it. Same thing like the gray matter. If you give contrast, there is no contrast. And this differentiates them from craniopharyngiomas, from hypothalamic gliomas, and others. In addition to that, craniopharyngiomas and pituitary tumors in that area, they present early with endocrinological problems. And this hypothalamic hematoma, they just have the precocious puberty. Again, so this is T1 with contrast, no contrast enhancement. T2, as you can see, iso, so hyperintense a little bit. And this T2 showing the mammillary body being distorted, as you can see here. And this is the FLAIR MRI. So if you know the MRI characteristics and if you know the history of the patient, the elastic seizures, precocious puberty, etc., you can come to the diagnosis. Can they be cystic? Yes, in a very minority of cases, 3% only, and only in those large tumors, large volumes. So you can see cyst there in the hypothalamic hematoma. They can be small, they can be medium-sized, they can be giant. And they can be diagnosed in utero. Now this is in utero, it's showing this hypothalamic hematoma, and when the patient was born, followed up for 2 months, and the MRI showed a giant lesion. So this was a 37 gestational week, and this was 3 months old. They can really attain a giant size, giant solid cystic, as you can see, going into the posterior fossa and the transtentorial, causing hydrocephalus. Other images that you can do is the spectroscopy, and you look at the various components, N-acetyl aspartate or choline, and etc., to see kind of lesions, and this is one of them. There is increased in choline and myoinositol, and there's decrease in creatinine and decrease in the N-acetyl aspartate. And this tells us that this is a neural density thing. You may find that the ratio here is decreased or increased. You can use the SPECT, single photon emission computed tomography, and then you will find that during the attack it is normal, while after the seizure there is hyperperfusion. So you can see this is ictal and this is interectal. Interectal and ictal. The difference between here interectal and here and ictal. PET scan also can give you a clue, the hypometabolism in interectal and hypermetabolism in ictal. You may use functional MRI if you want to operate, etc. And you can use the MEG, the magnetoencephalography. This is the functional MRI. You may need to do pelvic ultrasound, as I said, to see the volume of the uterus, whether there is endometrial tissue in the uterus, and the cervix and so on. So brain MRI, you have to do it in all boys. Why? Because most of the time there is secondary cause for their precocious puberty. While girls, just wait a little bit because 80% of them is idiopathic. You need to do full psychological assessment for the patient, the memory, the Whistler intelligence scale for children, the modified ones and the usual ones, and the adult intelligence scale. It's important to do it in details. I refer my cases to our psychologist here, Dr. Walid Sarhan, and to Dr. Samawi to do these cases for us in all patients with the brain lesions in the area of the hypothalamus. And they spend like sort of 6-8 hours to give us the result. And they repeat this before surgery and after surgery. And I hope if one of them is on the panel to come forward and at the end of the lecture and give us some, shed some light on this important investigation. Can these hypothalamic hamartoma be associated with other lesions? The answer is yes. They will be associated with changes in the gyri and changes in metabolism and perfusion. So this is a list of the things that you can see with the hypothalamic hamartoma. Atrophy, leukomalacia, corpus callosum hypoplasia, periventricular leukomalacia, polymicrogyri, perivascular gliosis, etc., etc. So when you look at the MRI, look carefully if you see hypothalamic lesion. So this is an example where there's a cortical maldevelopment in this patient with hypothalamic glioma, hypothalamic hamartoma. And when you see one, you have to differentiate, you have to have the differential diagnosis like in everywhere. As I said, craniopharyngioma enhanced, optoglioma enhanced, hypothalamic glioma enhanced, ganglioblastoma enhanced, but the hypothalamic hamartomas do not. Examples of the things that you have to remember in the differential diagnosis there of germinoma, histiocytic sarcoma, craniopharyngioma, histiocytosis, optoglioma, arachnoid cyst, astrocytoma, lymphoma, all in that area. You will need to do EEG for these seizures. And those patients, poor patients, they can have up to 300 seizures. So you may need to put them on a video encephalographic recording. As I said, the hypothalamic hamartoma is the one that generates this icter. So you can actually confirm this by to see ictal discharges confined to the hamartomas, whether these lectures that you have put are in scalp or in the sphenoid bone or even in the hamartoma itself. So this is an ictal EEG. You can see it's mainly in the frontal area, in the central area. It can progress, it can propagate to various other areas of the brain, and then end with various forms of epilepsy, generalized, clonic, drop attacks, partialis, complex, etc. So you have to remember that it can propagate to other cortical areas, and this is secondary epileptogenesis. But the main generation of this activity is in the hypothalamic hamartoma. And they can even go into status gelaticus, like status epilepticus. Interictal. So you can put depth electrode here, depth electrode into the hypothalamus, and here there are depth electrode in the temporal bone and temporal, mesial temporal to know exactly where is the discharge coming from. And you can see angelastic seizure here with atonic seizure, subclinical attack, subclinical ictus, and this is, you can see on the video encephalogram. We are coming now to the treatment. Basically, you can see that the treatment is challenging. Some people give, as a treatment for this epilepsy, the gelastic or the others, they give ketogenic diet. High fat, 90%, low carbohydrate, low protein. It is said that ketone bodies, this diet will produce ketone bodies, and that will decrease the intrinsic epileptogenicity of the hypothalamic hamartoma. What do we mean by ketogenic diet? Like this, rich in fat, you can see, all rich in fat, but low carbohydrate and low protein. Papers, a lot of papers have been written about ketogenic diet and the treatment procedures associated with hypothalamic hamartoma, but in large, they are not very effective. You can give medications for the epilepsy itself, anticonvulsant medications, but they are largely ineffective. You can put vagal nerve stimulation, largely ineffective. You can give corticosteroids, largely ineffective. Some people give calcium channel blockers, but their significance is not yet realized. We come to the major management of these lesions. In addition to treating the epilepsy, you need to do something for this lesion because of the various factors we mentioned. And then we go into microsurgical resection, or resection by endoscope, or radiosurgery, or thermocoagulation, or interstitial radiation, or putting DBS, deep brain stimulation for the epilepsy. The indications of surgery here are uncontrolled seizures, which is usually the case, as usually it is associated with behavioral problems and failure of medical treatment of precocious puberty. Where would you attack? You have to know the site of the lesion by looking into the EEG dominancy of the seizure or dominancy of attachment. Is this hamartoma attached to the right side or to the left side? Is it one side or bilateral? And one thing important is the asymmetric smile during gelastic seizure. This is important to remember. Do it on the contralateral side. These are the electrodes, the scalp electrodes. They could be sphenoid bone electrodes. They can be on the cortical surface, the strip electrode, and they could be electrodes that are inserted into the hamartoma itself. And then you can have preoperative EEG recording and postoperative EEG recording, and this would be defined as a successful treatment. But remember, whatever you do in that area of the hypothalamus, the 4 grams of tissue there, which control our essence of life and development, you can have all sorts of complications related to the site, related to the procedure, meningitis, memory disturbance due to injury of the columns of the fornix, hemiparesis because you come very close at the foramen of Monro to the internal capsule. It is just 1 to 2 millimeters from there. You can cause thalamo-capsular infarction because you affected the perforator branches from the basilar artery, brainstem infarction, diabetes insipidus, panhypopituitarism, weight gain, hyperthermia, etc. This is an example of the complications, thalamic infarct. Let's see them one by one. Open surgery, you will do craniotomy, and your aim is to do craniotomy for either resection or disconnection. What do you mean? People found that there is no reason to do radical resection. You just need to do disconnection between the hamartoma and the surrounding hypothalamic structures. You can go transcallosal, terional, subfrontal to the lamina terminalis, whatever way the tumor takes you. So, terional approach, you'll be attacking it this way. Transventricular approach, attacking it this way. Transcallosal approach, attacking it this way. These are open surgeries. And this is an example of this. This is the optic nerve, this is the carotid artery, and you can see the hypothalamic glioma is presenting itself laterally. This is the type 1 of the hypothalamic hamartoma, and this is after excision. Remember, there is absence of a clear border between the lesion and the surrounding tissue, so you don't need to be aggressive in surgery. And this was clearly established by the Landy and Fonin, which they have put the classification for these hamartomas, that the concept of disconnection was born, that you just disconnect the lesion from the hypothalamus. So if you are going this way surgically or endoscopically or whatever, you just disconnect here. You can remove part of it, The main thing is to disconnect here. So disconnection surgery. So resection or disconnection. The morbidity and the open surgery is 30%. Seizure control is something like 90%. Examples of papers about these approaches for these lesions, you can see it here. Pre-op and post-op, here and here. Again, here the transcallosal approach, you can see the floor of the third ventricle, and you can see the hamartoma. Again, you find difficulty differentiating both. The TAIF, anterior transcallosal transseptal interforniceal approach, which is an example of the open surgery we mentioned. As you can see, you can go in there between the two fornices here to reach to the hamartoma. Either open surgery or endoscopically. Transanterior interforniceal approach, that's the hamartoma. You can see the columns of the fornix here and the anterior commissure here. You may use the endoscope, and I keep saying that endoscopy holds the future of neurosurgery. The advancement that has been made in that specialty is tremendous, and endoscopy is an important subspecialty. Either the endoscopy is used for resection or disconnection. I will use it for just endoscopy thing, or you can couple it with laser treatment and so on. So this is endoscopy treatment. You can couple it with using of lasers, or you can do the regioning by monopolar electrode. Endoscopy, as you can see here, the laser being used. You can have robot-assisted endoscopy, and this is a paper published 2018 in France. 136 patients, and they attained about 60% seizure-free with low complications. Again, a paper in pediatric neurosurgery, disconnection of hypothalamic hamartoma, and you can see here the effect. Pure endoscopy for the lesion, you can see you are disconnecting the hamartoma from the surrounding hypothalamic structures. You can use radiosurgery, and radiosurgery will mean a gamma knife, linear accelerator, or you can use a new concept, interstitial radiosurgery. The old name is brachytherapy. So radiosurgery offers a great deal of important management tools here. Gamma radiosurgery, effective treatment to control seizures with superior result of a neurophysiological outcome compared to microsurgery. I keep saying this, that we had the first gamma knife in Jordan back in 1996, June 1996. That was the first gamma knife in the Middle East. And I have used the gamma knife then and afterwards, 96 and afterwards, for treatment of hypothalamic hamartomas, as I will show you. So the morbidity is less, there is no surgery, and there is good 37 to 45% of seizure control. It is less effective than the others in terms of seizure control, but the morbidity is very low. Famous paper about radiosurgery and gamma knife was published by John Regis of Marseille in France. He published several papers. Last one was in Epilepsy Journal 2017, and you can see the isodose of his treatment. 82 patients. And this is the isodoses and the blocking of the radiation to reach the optic apparatus, which is a main concern. But nowadays, with the new gamma machines, you can actually block the rays. Another paper, again, by John Regis about gamma knife being used and can preserve endocrine functions. Again, showing you the isodoses. Interstitial radiosurgery is to use radioactive iodine 125 and put it temporarily in there, either single or multiple sources. As I said, the old name is brachytherapy. Paper published in Neurology 2007, treatment options of gelastic epilepsy due to hypothalamic hamartomas interstitial radiosurgery. It is effective with a good number of patients, 38 patients. Again, the interstitial radiosurgery using the seats. Now they are implanted. Again here, the optic apparatus, optic chiasm, optic nerve, and the hypothalamic hamartoma. So you can put one seed or more than seeds, and they will give you the radiation. You can use it once or twice or 3 times, and it will start having central necrosis surrounded by a rim of increased permeability. Examples of the lesion that you can see on the MRI. Another method of dealing with these hamartomas is thermal coagulation. And this you can achieve by doing radiofrequency thermocoagulation or ultrasound focused thermoregulation or laser robot guided stereoendoscopy or LIT, laser interstitial thermocoagulation. The seizure control rate is good, complication rate is low, and it is favorable outcome. I have to tell you, reading the literature, thermoregulation is taking the upper hand with gamma knife over the surgery. So radiofrequency thermocoagulation, as you can see in here, stereotactic insertion of depth electrode in the hamartoma, and then recording or doing whatever you want to do. So this is 24 hours later, you can see the effect of this radiofrequency. It is immediate. While in gamma knife, you have to wait about 1.5 to 2 years to see the effect. In surgery, the complication rate is high. This was pioneered by Nishi Nigata from Japan. He presented 100 patients with very good seizure-free control and a very transient complication rate. Again, another paper about the stereoelectroencephalography guided radiofrequency thermocoagulation, or the so-called SIG guided radiofrequency thermocoagulation. Various papers published on this matter, mainly from Japan, using the stereotactic radiofrequency thermocoagulation. Here, this paper, they reported 100 hypothalamic hamartomas. As I said, it's called SIG guided, meaning stereo electroencephalography, and is associated, it's coupled with radiofrequency to achieve thermocoagulation. Laser has been used from a long time ago, but now it is so much refined to treat the hypothalamic hamartomas with laser catheter being inserted into the hamartoma. And this is called MRI guided laser ablation of these tumors. Many papers published on this, and this is really gaining popularity among the neurosurgeons. MRI guided laser thermocoagulation. This is a paper from Barrow Institute in the United States, 51 patients using this LIT, laser interstitial thermocoagulation. Another paper from in epilepsy 2017 of 8 patients. 6 of them had seizure freedom. Another paper, epilepsy 2013, 14 patients, very good high seizure control. Again, paper 2018, 179 patients from 225 reports. This is literature review. So coming to the conclusion about these methods, LIT seems to be a very favorable seizure outcome with low rate of complications. It has an immediate efficacy, and this is the advantage over gamma knife or conventional radiation. Stereotactic laser ablation in the Kenyan paper in 2018. And you can see the immediate effect. And this is the major advantage. I will show you some of my patients and then we are through, finished. This is a patient of mine. This is the hamartoma, as you can see. This is pre-treatment. This is a lady, 22-year-old lady. I treated her with gamma knife then back in 99. And this is the gamma plan. And this is the post-gamma, some reduction in the size of the lesion and some improvement in her condition. This patient, a 17-year-old female patient, also presented with this hamartoma that I treated with gamma knife. And you can see there is some necrosis inside afterwards, as you can see. This is the gamma plan, and this is the necrosis. This is very interesting. The one-year-old patient, which I showed you the slide with his adult genitalia, one-year-old with an adult genitalia, and this is the hypothalamic hamartoma, and this is the gamma knife back in 97. And of course, you have to do it on the GA. He's a child 1 year old. He will not stay put. So this is our anesthetist, Dr. Jamal Sharif, putting him to sleep with monitoring. And this is his genitalia, adult genitalia. And this is the post-treatment with major reduction in the size and improvement in his precocious puberty. Last patient is this patient. So I showed you 3 cases that I treated with gamma knife. And this case is 1.5-year-old male patient with this hamartoma. This is before surgery, open surgery, and this is after surgery. And you can see the approach. It was the terional approach. So in conclusion, I finished now. People would claim different approaches as the best. People who do surgery would say it is the most effective treatment. Others may disagree. People would say gamma knife is the best. You need to wait. It's good. It's a good tool to use, but you have to wait for a result. It may be the thermocoagulation or the laser. These seems to be significant advances recently. But remember, and this is the conclusion, no single neurosurgical approach is likely to treat all forms of the hamartoma. This is a child who had gelastic seizures, and she was cured by laser treatment. With this, I finish, and I'm ready to take your questions and comments. And I hope if we have any neurologists or histopathologists or psychologists, psychiatric specialty, to come forward and discuss things with us. Thank you very much. John?
Thank you very much, Dr. Sabaya. You've obviously put a lot of work into that.
Yeah.
And we have a couple of, I know we, as an announcer or a host, one thing you always dread is dead air where no one says anything. But we have 3 people here, Radab, Dr. Kabulo, and Dr. Zayden. I know that they all participate. So I know that one of you 3 guys has a question, and anybody else, of course, is welcome. Okay, we're open now for questions or comments. Is that dead air I'm talking about? Come on, Dr. Kabula, are you there? Maybe he may have stepped away. He was here earlier.
Sure.
Verdab, are you there? Wow, I'm striking out everywhere.
We should have put some questions like we used to do.
Yeah, I think in the panel, let me, there was one question I saw in the panel. Let me check that there. Okay, yes, a question. Dr. Abu Bakr, I think he's from Sudan.
Yeah.
My question is, according to what is the priority to do surgery or endoscope or other radiation treatments in treatment of hypothalamic hematoma
Yes.
condition that we can use?
As I said, if you look at literature and if you look at the practice and even my personal practice, surgery is falling as a main thing for the treatment of these cases. And if you want to do surgery, you have to do the disconnection. You don't need to do radical resection. Radical resection in the hypothalamus is very dangerous. So you just need to do disconnection. And if this tumor is presenting to the ventricle, you don't need to disconnect there. You need to disconnect to the wall of the hypothalamus. So surgery is a good example, but you have to be experienced with this kind of surgery. If you have endoscopic experience, go ahead and do endoscopy. If you have a good radiosurgery team, go ahead and do radiosurgery, gamma knife or others. But as I said, recently the vogue is for the thermocoagulation, whether you are using laser or radiofrequency or the other. Now remember, these are not available in every country. Radiofrequency or laser guided is only present maybe in a few centers in the States and in a few centers in Europe. So depending on your capacity, your expertise, the facilities that you have, you choose whatever is good for your patient.
Very good, thank you. And I'm glad to see Dr. Zayden has pulled up his chair. How you doing, Dr. Zayden?
Yes, good evening, Dr. Bennett. How are you?
Good, how you doing? Do you have any comments or questions for Dr. Subeh?
Well, actually, I want to congratulate Dr. Subeh. He did an immense work and research in such rare disease I mean, he's still lucky to have 3 cases in his career. I mean,
4 cases.
it's rare, 4 cases. It's very rare to see such cases. During my presence in France, I saw 1 only, and actually we did stereotactic biopsy for it because initially somebody thought that some sort of glioma at that region. And later on, we had some trouble of operating such patient, and there was plenty of debates around going to operate or what to do exactly. And then we did, we sent it to the radiosurgery center, I mean to the stereotactic radio. I put her the stereotactic frame in the South Hospital in Lyon, and we did that for her. Luckily, I wasn't able to follow her properly. That was the only case I saw in my life, actually. And I mean, Dr. Subeh, you are very lucky to see 4.
Absolutely.
I mean,
absolutely.
it's very rare disease. I really congratulate.
Thank you, Abdullah. Thank you very much.
I really congratulate you too much, and it's usual. I mean, you are giving your beautiful feast of rare cases. I mean, I'm really happy about that.
Thank you very much.
Thank you very much.
And that's why, Abdullah, I choose to discuss this topic. It's rare. It is usually misinterpreted, misdiagnosed. And even for people like families, I think if doctors would speak to families that not every child is laughing because he's happy, maybe he's having elastic seizure. So I thought it's an eye-opener for us as doctors, as surgeons, and what is the new advancement in the treatment of this disease.
Okay, we have a question in the panel, Dr. Subeh, from Vanessa. What is the incidence reported in the literature for asymptomatic HH?
Very rare, extremely rare. Most of the time they are symptomatic, but as I said, in every case, even if a meningioma, I always say about a large meningioma presented to me in a man, 70-year-old, and he was asymptomatic. He just had MRI because he hit his head against the door, and he was totally asymptomatic. So whenever you have a patient who has no symptoms, no signs, with an intracranial lesion, just slow down, put brakes, and wait. Maybe this is asymptomatic. And I showed the autopsy specimen in that man who died of car accident but had this hypothalamic hamartoma. The percentage of asymptomatic is very, very small, but remember it.
Okay, very good. Vanessa also remarked that dacrystic is a Greek word originated from the word dakryon, which means tear. I don't know
Exactly.
if you're a student of Greek mythology.
Yeah, I mentioned that in my slide.
He mentioned that in the
Oh, okay. Oh, okay. I'm sorry.
Elastic is laughter and dacrystic is tear. So as we see it in the videos, They can laugh, they can cry, you can have mixture of both.
Okay, very good. Very good. You can never get too much Greek mythology. Okay, any more comments, questions from anybody in the panel? You're certainly welcome.
Well, I think, Dr. Subeh, I think this lecture should go again to the people of psychiatry and psychology. I think that there are maybe it's very rare because we are not looking for the disease. We are not investigating, doing MRIs or CT scans for such. I mean, these children maybe are titled by having autism or some.
Absolutely.
Yes,
Absolutely.
or some mental disorder without even having an MRI or CT scan in their age or something like that.
Yeah.
Well,
Thank you
I
for
think this is
what
very
you
important. If you can just say this lecture again for our colleagues in the psychiatry departments and these things, and it's our duty also to propagate this again.
In fact, all my cases of brain lesions, I ask for a psychiatric consultation, pre-op and post-op. Especially when you have a colloid cyst, you want to know the memory disturbance, etc., etc. But it is a rule that I have psychiatric consultation for my patients pre-op and post-op. And this thought came to me when I was in England, training there, and I heard about a study that has been done in a famous hospital in London called the Priory, very famous psychological institute. And they did a study that was in something in the 80s. They just decided to do CT scan for those patients who were instituted in the Priory. And glory, glory, they found about 12% of them, they harbored brain tumors. And while they were instituted for, psychological reasons. From then, I believed strongly that neurology, psychiatry, and the neurosurgery are one team, and we should always cooperate. Some neurosurgeons behave as if they are neurologists. You cannot be a neurologist. You cannot be a psychiatrist. You cannot treat patients with Parkinson. You should not treat a patient with epilepsy. You are a neurosurgeon. And on the same token, a neurologist, leave alone the disc disease, leave alone the brain tumors because it is not yours. Same thing for the psychiatrist. We are one team. And the hospital I trained in, the Atkinson Mori at St. George's Hospital in London, we had the three departments in the same building. So that's why I got this, neuropsychiatry.
Neurosciences department.
Absolutely.
But may I ask who referred the 4 cases to you? It was by psychiatrists, by neurologists?
No, it was by the father or the mother, mostly the father. Seeing that the patient has a precocious puberty or having gelastic seizures. So most of the time they notice that this is abnormal behavior. But usually they are advanced. They have major psychiatric, major cognitive, precocious puberty, etc., etc.
And who sent them to the neurosurgery service? I mean, how did the parents came to know that maybe this is caused by a tumor? Or
they knew there is something wrong with the brain, so they decided to come forward. In Jordan, and like in most countries in the Middle East, people don't differentiate between neurologists and neurosurgeon and psychiatrists. They would come to you for depression, they would come to you for osteoarthritis knee, they would come to you with Parkinson, but it is your duty say, stop, this is not my specialty. I'm specialized in brain surgery, go to the neurologist or go to the psychiatrist.
And you only discovered these 4 cases by yourself?
Yes, by just doing MRI.
So that's why I insist again, just we have to tell our colleagues in the neurology and the psychiatry that they have to look again and do MRIs for such patients.
In fact,
and the endocrinology also.
I asked a few of our psychiatrists to be with us today, a few of our neuropathologists to be with us today. I can't see no one on the panel. This is the opportunity to discuss these problems together.
We would like to have their opinions, yes.
Absolutely.
Yeah, Dr. Zayden, in that vein, you can also get a copy of this video in the YouTube channel of Neurosurgical TV, and I'm posting it in the chat. Anybody that wants to see a copy of this video, as you alluded to, that other people want to see. this type of information, psychiatrists, etc. Okay, there's a remark by someone here on the chat. Verdab, are you there? You can ask it directly if you prefer. Okay, one from Napoleon says, what is your preferred open surgical approach?
Well, it is not a preferred approach. Your approach is decided and dictated by the tumor. Do you need to go to the tumor from below, or do you need to go to the tumor from above? Below, the tumor needs to be denucleated or going down. If it is not, then you have to go from above. That is transcallosal, and then you go into the foramen of Monroe and into the tumor itself, choosing whatever method you like to choose. But it is decided and dictated by the tumor, whether it's type 1, type 2, 3, or 4.
Okay, very good. Let's see. Verdab, do you want to make that remark directly to Dr. Sabea, or I can just read it?
Yes, hi, Dr. John. First, thank you, Dr. Professor Spey, for the tremendous ongoing work, and this is such important and rare topic to be discussed as usual. Actually, I was just wondering about one point, that the commonality of the precocious puberty in adoption. I just couldn't pick up what is the scientific background of this relation between adoption and...
It's an observation. It's an observation that adopted children, they get precocious puberty. It's not they develop hypothalamic hamartoma. As we said, in girls, 9, and girls 8, and in boys 9. So 8 in girls, 9 in boys. If they develop it before that, and most of the time in girls it is idiopathic, and they found that most of the time you have some element of either emotional problems, and these are common in those adopted children. So it's an observation. Why psychology plays an important role.
Okay.
Yes, Verdab, thanks for participating.
Thank you. Always my honor to attend those lectures,
Okay,
Dr. John.
It's always good to see you here because I know you're going to participate.
Thank you.
Okay, anybody else would like to make a comment or ask a question? We're open here. Okay, well, I guess I'll thank you, Dr. Sabea, and ask you if well, I guess the schedule is going to be kind of strange here. When is your next scheduled talk, Dr. Sabea?
I have not decided, but it depends on you because we are coming to festivalities. So what do you think? Should we make one next week? And then
Yeah, next week could be great.
Yeah, and
would
then
be
wait
great.
for the Christmas holiday.
Yeah. Okay, we'll keep in touch, but we'll just schedule next week because we really
Sure.
haven't started the Christmas season.
Yeah.
Okay, very good.
Thank you very much.
Thank you very much, and thanks everyone for participating, and we'll see you next week.
Thank you. Bye-bye.
Bye-bye. Okay, very good. That's a wrap. Yeah, it went well. Okay, yeah, and certainly there's getting to be more interest. Things will slow down during this season, but there'll always be something to look at. So I'd like to thank you, Dr. Sabea, and I'll send you, yeah, it'll be on the YouTube channel.
Keep safe. Bye-bye.
Okay, thank you.
Bye-bye.
Thank you. Very good. Now, Anjali Thakkar, are you still there? Because I appreciate it when you send me thanks for sending them. You're one of the few people that does that. Okay, anybody else want to come in and network? You know, eventually, you guys don't have to. You're welcome to, but this will eventually be networking after the conference. Just like when you go to conferences in person, you know how you really forge some great relationships at those conferences and not just forged relationship, but you have a passing relation where you meet someone, that's how I got a lot of my jobs, was after conferences, networking, meeting people, etc. And this platform will be used in a similar fashion in times like right now, where we'll eventually get comfortable with it. I've been doing this for years, so it's no big deal for me to do it. But are you still there, Verdab? Oh, Fatima. Fatima, you came. Okay, great. Great. Come on in, Fatima.
Hello.
Hey, how you doing?
How are you? Fine.
Okay. Everyone else is welcome to stay, but me and Fatima are going to work something out. She gave a great talk on flaps. She's from Iraq, and we're trying to straighten out the logistics of because this platform, once you guys learn it, as Fatima will, it's a good working platform. We've been Fatima and I have been trading emails as well as Dr. Semmer about how to get something done. And you know what, Fatima?
Yes.
When I start trading emails with people, I say, let's cut the bullshit. Let's just talk face to face.
Yes.
That's how you get things done. So we're going to get this done this way. Okay. Now it's all yours, Fatima. You can screen share and give me instructions to do this. Okay, let's do it.
Okay, I'll start sharing the screen.
Okay. Everyone else is welcome to watch how we do this. It's not no big deal.
Okay, I send you about the Dropbox link.
Right.
You said when you first click it, the 50-minute video start.
Right.
Yes.
So you want me to open that now? Okay, you can show me, and I'll just wait. I'll just wait to do things.
Okay. So as I tell you, it's just a preview. Now I really have a bad connection, so.
Okay.
Yes. Yes. Look, John, this is.
This is what I need to see. Okay.
Minute. Yes.
Right.
This 50-minute is just a preview. So.
Oh, okay. So when I click that, it's just a
15
15-minute video.
Yes. Look, it's
you know what I mean?
15.
It says, let's see, it says 15 minutes. I thought, wait a minute, those presentations were like an hour.
Yes, it's a 43-minute.
Yeah. So okay, so you download the whole thing, right?
Yes. When you click, when you just click direct download, it will start downloading the full video. Although it's the preview is a 50-minute, so.
Okay. So I need to download it.
Yes. It's, or you can add it to your Dropbox.
Okay.
Dropbox.
You see how that by showing me how easy it was.
Yes.
when Samuel was writing emails and it's like, whoa, man.
Yes.
And now I understand. Okay, so we'll get it done.
Okay.
I'll do it and send it to you. Okay.
Okay. Thank you.
Very good. Okay. Thank you very much.
No, welcome.
And everyone else watching can learn that this platform and the video are the best way to get work done. Not trading emails, because whenever I start trading emails, I go, whoa, wait a minute, let's talk to each other and get it done. So, okay, very good. Okay, I'll get that done right now. And I'll